I want to turn our attention to the control arms in these studies because everybody is comparing to sunitinib, in particular sunitinib, 4 weeks on, 2 weeks off. Now, I mean, there have been comparisons to sunitinib 4 weeks on, 2 weeks off with pazopanib, and we've seen a very different side effect profile. Walt, do you have thoughts on that study, the COMPARE study, and how do you interpret that now in the context of these ongoing studies?
Well, I mean, I think that the control arm of sunitinib at the FDA-approved schedule gives the companies the greatest potential for winning in the IO combinations. In essence, because the 4-2 combination is difficult to tolerate and has real problems. And most of us and most practitioners in the community will rapidly switch to alternative schedules, and there's data to support that, or use an alternative TKI such as pazopanib. And that is not part of these particular trials. And so therefore, I have some concerns that in essence, dose intensity in the control arm is not ideal in these particular trials. And that, once again, leads back to my contention that, gosh, survival really has to be observed in order for me to change my practice.
I would add, though, Dan, that we don't have any randomized phase 3 trial to compare 4-2 versus 2-1. We have one study published in Annals of Oncology that showed 2-1 is really better tolerated and has better efficacy, but we recently had a paper published about the 2-1 schedule where the primary endpoint was grade 3 events and what was not different between both arms.
Yeah, I guess I was less worried about that regimen and the data we do have, which is the COMPARE study, which you were part of, Tony.
Correct.
And there we have a clear difference in safety signal, no difference in efficacy between sunitinib and pazopanib, but a difference in safety signal. How will you compare that safety signal now to the signals we're going to get from these?
I would not say safety, I would say tolerability.
Okay,
because the treatment discontinuation for side effects from pazo and sunitinib and the death on trial from this drug were not different. But from tolerability, that's an issue. And people have used all kinds of sunitinib schedules. And I do agree that pazopanib, in general, not overall, is better tolerated. And that's going to be an issue. And we may revert back to what Walt said initially, overall survival, which is going to be a problem because patients on sunitinib going to cross over and get standard of care checkpoint blockers.
That's right. In particular, the good risk, because most of these studies that are being done now with IO plus VEGF are being done in all comers, not necessarily in the intermediate poor risk.
Correct.
So how are you going to look at the good risk patients within that study and begin to say, do we see an overall survival benefit there?
It's going to be very hard to
Or
interpret.
is it skewed by the other group?
Yeah, it's going to be very hard to interpret that data. I mean, I think, everybody's very excited about, axitinib and Pembro having a response rate of somewhere, I think, in the 60s or so. But, if you look at, for instance, sunitinib and the CheckMate 214 and the favorable risk, that was over 55% right there. And so you're wondering how much of this is the combination versus if you sequence these. I'm not totally convinced VEGF plus IO is going to be better overall. Maybe for some, but not for all, necessarily for all. And hopefully, I think we'll have some better biomarkers to help guide us. Like who's going to be VEGF by themselves, who's going to be both, who's going to be just IO. That will hopefully be the future of kidney cancer.
You brought up the word sequential, and I wasn't sure where you were going to go with it.
That's our next section.
But, the challenge around this table, in my opinion, is everything's combining two drugs. And you pick your two drugs based on who's ever in that back room that wants you to do the study. But why aren't we looking at these drugs sequentially? What should come first? Which TK drug augments the immune system to make an IO ripe to work? Right. And you sequentially study that.
I think that's a great question, Bob, and I think that's why we're looking at the OS here, independent of the progression-free survival, because that first progression, might look significant, but that second progression, to your point, the sequential treatment, might even out. And so, but if we see an overall survival signal, then presumably that second progression, which is just hard to measure in studies, would also have been beneficial. So that I think is the strategy, and I think we need to be careful when we interpret these studies going forward on just how much of a clinical benefit are we really.
But the other point that
really
was brought up, you brought up the inflammatory issues around both fields. If you do it sequentially, well, you're going to know which of the drugs are creating the more likely inflammatory component, whether it's the colitis, whether it's the hepatitis. You'll know. You'll have a better feel.
And that's a great way of phrasing it too, because I think that's right. When we can decompartmentalize the toxicities, we know how to manage them. We've done that. This is going to be new, trying to manage, toxicities that might be related to both agents, and that's something we're going to have to look for in the
And we're
future.
in an era, and I'm a big cisplatin fan. I grew up studying testis cancer. That's our drug, bladder cancer. So you knew what you were dealing with. Here, these drugs don't go away. They have to stay on them chronically. So what are the chronic toxicities a year later, from being on maybe a checkpoint inhibitor or being on a combination of these drugs? And economically, the pocketbook for these drugs is steep. So you can't, stop these agents without potentially seeing exponential progression or progression. So how do we educate not only ourselves, but those that are out there?
Yeah. More questions than answers, I think, is how I would summarize this section.